Good afternoon, everyone. Thanks for joining us for today's discussion. I'm Dante Prayer, the HIV Program Manager for the Center for Black Health and Equity. And we really appreciate you guys taking your time out today, especially during your lunch, to have a critical conversation about an outbreak that has been plaguing the world, especially Black people. And so now we'll just jump right into the conversation. Joining us for this conversation, we have Dr. Brianna Birch, Greg Millett, and Dr. Jeffrey Jinks. And I will let them introduce themselves as way they see fit, and then we can get it going. Again, thank you guys.
Hi, thanks everyone for joining this morning. And well, morning for me, I'm based in Seattle. I am Brianna Birch. I am an infectious disease physician specializing in HIV and STIs and parasites, which is one of the fun things that we don't really have in America, but they're all over the world. So I'm currently at Fred Hutchinson Cancer Research Center, not as an oncologist, but based here in Seattle, and happy to be here with you all. I don't know who wants to go next.
Go ahead, Greg.
Oh, sure. Hi, good morning. My name is Greg Millett. I am the Director of Public Policy at AMFAR, the Foundation for AIDS Research. By training, I'm an infectious disease epidemiologist. I was an epidemiologist at CDC, senior epidemiologist for 15 years before moving to Washington, D.C. to write President Obama's national HIV/AIDS strategy, and then stayed at the White House to implement it. And my team and I are involved in mainly global HIV work, though I still do some domestic HIV work, as well as domestic COVID-19, and now, unfortunately, monkeypox work. But glad to be here. Thanks for the invitation.
Good morning, everyone. Good afternoon. I'm Jeffrey Jinks. I'm the Laboratory and Medical Director at the Durham County Department of Public Health in North Carolina. I'm infectious disease trained. Prior to this, this position, I was at the University of California in San Diego as a academic physician. So I've been involved in clinical work for quite some time.
Thank you guys so much, and we'll kick it off with Brianna. Thank you so much.
Excellent. Okay, I will share my screen. And let's go to presentation. I can see you all, so I think you can see this too. Okay, so let's talk about monkeypox. So this is a chart of what the world is looking like. Well, America, not the world, I apologize. Looking like, this is from last week, but these are the cases from May 15th, which is when we had our first case in the States, all the way through August 24th. And as you can see, it's starting to just kind of crescendo up a bit. And we're still kind of here, but as the United States progresses, we are starting to sort of plateau. So, just kind of keeping our eyes open for things. I live in Washington State, which is up here, and we've had 520 confirmed cases, but the total cases from the states are just over 22,000. And so you can see where it's kind of hitting our nation the hardest. And this slide is from just last week. And as you can see here, the age that it's affecting the most, we've got 18 to 34-year-olds and 35 to 49-year-olds, which is to be expected because this is a, excuse me, this is a virus that likes to be around people who are socializing a bunch, who are hanging out with each other a bunch. And so that's what we're going to see. This is the age group for that. It's affecting mostly cisgender men. And these are men who mostly are having sex with other men. And as you can see, it's affecting kind of all populations, but we're seeing this a lot in white males and Hispanic males, or Hispanic people altogether. But yeah, this is what our breakdown is looking like so far. And this was updated a few weeks ago. So what is monkeypox? It is in the family orthopox, orthopox virus. Also in that family is smallpox. So we'll talk a little bit more about that later. There are two clades, which just means they're sort of like sisters, right? They're siblings. Clades are like siblings. So clade 1 is one that we saw in the Congo, also known as the Central African clade, and it causes about 10% mortality. Excuse me, there's a lot of smoke in Seattle today from forest fires, so I've breathed some of that in this morning, just other stories. And then we have clade 2, which is the West African clade, and you're gonna see less than 1 to 3% mortality involved with that. And what we're seeing in the United States right now, we're seeing clade 2B, which is like a half sibling of clade 2. So monkeypox is a virus that is similar to smallpox, but the symptoms are less severe. It was first discovered in 1958 after outbreaks occurred in some monkeys that were kept in Denmark, I believe, for research. And the virus was primarily found in parts of Central and West Africa, but in recent months, it's spread to dozens of countries, especially the United States, and it's been infecting tens of thousands of people, and we're seeing this overwhelmingly in men who have sex with men. So like we said, yep, Denmark, there we go. So some monkeys first had it, where they noticed it in a lab in Denmark. So these are research monkeys, and they were brought over from, we can only believe to be the DRC. And so we first started to see this in other countries back in 1958. In 2003, people were, starting to see a few cases in the US. We had 53 cases, and they were associated with imported animals, prairie dogs, Gambian rats. I don't know who wants to have a rat, but some people do. And they were noticing them on the virus lives on the pads of the paws of the animals. And in humans, excuse me, we started to see sustained transmission, meaning consistently transmission in humans in the DRC. Then in 2017, we had an outbreak of clade 2, and this was in Nigeria. And we think this happened because immunity to smallpox was starting to decrease. And so we were starting to get a little bit more susceptible to this orthopox virus. And then in 2022, we saw our outbreak here in Europe and the United States. So what are the symptoms? Mild symptoms, you may have a rash, but you might not. The rash may be limited to one body site, and most people have between 2 and 10 lesions. And this rash is, these are the pox. This is what we're talking about when we say a rash. We're talking about the actual pox. Common presentations, you might feel like you have a sore throat, or it's hard to talk. You may notice some lesions in your genital area. You may have difficulty going to the restroom, or pain or itchiness. So this is the biggest marker that we're noticing that's different than smallpox, is that this rash is going to be quite painful. People who get sick commonly experience a fever, headache, back pain, muscle pain, swollen lymph nodes, and just extreme fatigue. And a few days after getting the fever, most people start to see this rash. There are flat red marks that get filled with pus, and so nobody really wants that. On average, symptoms appear within 6 to 13 days of exposure, but can take up to 3 weeks. And we often see this co-infection occurring in people with syphilis, or a history of herpes, or gonorrhea, chlamydia, all of these kinds of bacterial infections. And so we want you to recognize the symptoms so that if it is indeed smallpox, if it is indeed monkeypox, then we can treat you and then also rule out other STIs that may be related. So this is what we're looking like with our timetable here. You will have your exposure to virus, and you'll have an incubation period. It's about 3 to 17 days. And then you start having this onset of symptoms, which we call the prodrome period. So this is the fever, the fatigue, the lymph nodes, all of this, the aches. Then if you get a rash, you will have that rash and it will last anywhere from 2 to 4 weeks. And then at the end of that, the rash will scab over and then you'll hopefully start to feel better. So this is what it looks like. We've got a macule, which usually lasts about 1 to 2 days, a papule, another 1 to 2 days. Then you start to get vesicles, right? It sort of looks like an ingrown hair, but not quite. Then you get pustules. So you start to see that the vesicle has started to fill and it looks a bit like a whitehead. And then you get the scabbed over lesions. So again, this is what we're kind of going to see. You've got this, this invagination of the vesicle happening, and then the whitehead that's filled with the pus, and then the crusts. I know that's not a word you really like to hear when you're talking about the skin, but you know, scabs and crusts. So how does this spread? Well, this virus spreads through close physical contact or by droplets. So if you happen to have these pustules, these whiteheads that are appearing in a painful rash and they become unroofed, so meaning the pus you're exposed to the pus, then that pus can get on clothes, it can get on linens, it can get on another person, and that is just filled with the virus. Another way it spreads is respiratory droplets. So if you're coughing, sneezing, if you are, you know, we work in STIs here, so we know that people are having intimate relationships. If you're making out with someone and you've got virus, you're going to give it to them via respiratory drops. The virus can also be transmitted from mother to fetus through the placenta or close contact after birth. If the mother has the rash that's on her body and she's holding baby, then baby can be exposed. So you would work with your obstetrician to find alternative methods for birth, probably C-section, et cetera, et cetera. So what do you do if you think you have monkeypox? Well, if you're just experiencing those flu-like symptoms, oh my gosh, spelling error, don't look at that. Those flu-like symptoms, the fever, the extreme fatigue, the swollen lymph nodes, the muscle aches, all of that, there's no way to really test to see if you have monkeypox at that point. We really want to, we have to test the actual pus from or not actually the pus, we have to take a swab from the actual rash itself. So that's when we'll take that, we'll take it to the lab, they'll test it and see yes or no if you've got it, and then we can start you on some treatment. So if you feel this way and you may or may not have a rash or you're waiting for your results, go ahead and stay at home, isolate, wear your mask. If you have to go outside or be in contact with people, wear your mask, continue to do your self-hygiene care, all of that good stuff. What's the treatment? If you get sick, monkeypox, with monkeypox, we have 2 types of treatment. We've got an oral drug, which is tecovirimat, known as TPOXX, or we've got vaccine, which is Jynneos, which is it's something that we use to also treat smallpox. And the good news about Jynneos is even after you've been exposed, you can still get your injections. So who should be, you know, prepared and getting vaccinations to prevent monkeypox spread? Well, those who are known or possible close contacts of people with monkeypox, people who know that one of their sex partners in the last 2 weeks has been diagnosed with monkeypox. If you've had multiple sex partners in the past 14 days in a place where you know monkeypox is high, there's a high prevalence of it there, or if you have a job or you're a healthcare worker or you work in a lab and you're seeing patients who are possibly exposed or potentially positive, or if you're working in a lab and you're working with the virus itself or with animals who have been infected with the virus. So this is the treatment. Tecovirimat is an oral drug. It's been given emergency use authorization, and we have safety data in humans, so it is safe. We have plenty of data in animals. The criteria for this is severe infection. So those at high risk for complications, if you're immunocompromised, if you're pregnant, et cetera, et cetera. Some of the adverse events: headache, nausea and vomiting, abdominal pain. If you are prescribed TPOXX, we do encourage you to take it with food. And what will happen is it will just reduce the duration of your symptoms. And so you'll feel better faster. Next is the vaccine, Jynneos. It is made with a live non-replicating virus. So what will happen is you'll get this injection, it's a series of 2, and it will not give you monkeypox. It's just a live non-replicating virus. And some people say that side effects include headache, muscle pain, injection site tenderness, everything that you would normally expect from getting a vaccination. What can you do to protect yourself? Get vaccinated. If you know or feel like you've come in contact with someone or you are in a high-risk group, then yes, get vaccinated. This is part of PrEP, the pre-exposure prophylaxis. So lab personnel, healthcare workers, et cetera, et cetera. If you feel like you've been exposed, but you didn't have vaccine, that's okay. You can still do PEP, which is post-exposure prophylaxis. And then you will be able to do TPOXX, or again, you'll be able to get vaccine. And then another thing to do is just reducing the number of sex partners or screening them, as in asking them, when's the last time you had sex? Have you noticed a rash on yourself? Things like that. It's a little bit difficult sometimes to negotiate these things before you engage, but we encourage everyone to just kind of, do a quick scan, a scan if you can. That's what I tell my patients anyway, and that's correct. That's what I say. So here's the question: is monkeypox an STI? We're seeing men who have sex with men. It's very prominent in this community, and it looks like an STI. It looks a little bit like syphilis. Well, no, monkeypox is not an STI. It's a regular virus. It's just transmitted through respiratory droplets or that rash, close contact with that rash. It's not stored, so far as we know, it's not stored in the body the way HIV would be stored. It's not transmitted in the way that normal STIs are going to be transmitted. It's simply close skin-to-skin contact, direct contact with that rash or respiratory droplet. So some myth busters: this virus is not new. The vaccine is not new. It's not more deadly or more contagious than getting COVID. It was not created in a lab. The vaccine is totally safe. If you've had chickenpox, this will not protect you from monkeypox. MPV is not an STI. And great news, you can get vaccinated even after you've been exposed. So some things to keep you safe. Well, do this. You've come to this kind of public health webinar and you've armed yourself with facts. So now you can protect yourself and protect your community. In so doing, you're decreasing the stigma because it's an uncomfortable disease / virus, but doesn't have to be deadly. We are framing this outbreak appropriately. It will affect everyone, not just men who have sex with men. It's not the new HIV. Sometimes you might hear that. It's not new, and it affects everyone. So keep doing what you're doing, continue to practice your self-hygiene measures, and keep yourself informed. And thank you all so much, and thank you to the Center of Black Health and Equity for having me. And these are where I got all of my information, and thank you. So I'll pass it off to Greg, who will be giving us some other things.
While Greg is loading, once they're done, we will have a question and answer. So if you have some questions, please put those in the chat and we will try to get some answers to those questions. Thank you so much.
Great. Hi, good morning, good afternoon. Thank you, Dr. Furch, for an excellent overview of monkeypox and what we're seeing in terms of this latest outbreak. I wanted to talk a little bit about this unique situation that we're in right now in terms of infectious disease globally, and really just the magnification of these infectious diseases of some of the racial inequities that we're seeing. So I'm going to expound a little bit about what Dr. Furch talked about this morning. The first thing that is really interesting is that most of my work is in global HIV or global infectious disease. And, just 3 or 4 years ago, we were all talking about the rise of non-communicable diseases and how infectious diseases, or the era of infectious disease, was over. And you saw this over and over again in domestic as well as global epi work, where people were talking about the rise of heart disease, the rise of diabetes, the rise of other non-communicable disease, chronic diseases, even in lower and middle income countries, and how infectious diseases were disappearing. And this is a model that the World Health Organization produced, where they're showing a rise in cancers and non-communicable diseases, and then how we are expecting to see a decrease in infectious disease through 2030. So given what's taken place over the last couple of years, I think we all know that that's actually not necessarily the case. Unfortunately, we've seen, emerging new as well as existing pathogens and infectious disease threats, from COVID-19, where at least in the United States, we have in excess of 1 million deaths, in the world globally approaching 7 million deaths from COVID-19. We're seeing the resurgence of polio in Europe as well as in the United States, in a place where I grew up in New York, where we're seeing particularly community spread of polio. We're also seeing a meningitis outbreak that took place earlier this year among men who have sex with men in Florida. There were 12 people who died from this outbreak, primarily affecting Latino, gay, and bisexual men. And we're also seeing, the rise of polio. Hold on for a second. I'm sorry, my dog is about to go crazy. Come here. So each one of these are things that I think we all find somewhat problematic that we're going to have to address at some point. In terms of monkeypox cases, it's the latest infectious disease that we're seeing, with 63,000 monkeypox diagnoses throughout the world. And here in the United States, about 24,000 monkeypox diagnoses. The interesting thing, though, is that when you take a look at the number of deaths, it hasn't been very deadly. Most of the monkeypox outbreaks that we've seen in Central and Western Africa have been deadly. This latest outbreak, we've only seen, thankfully, 23 deaths, but unfortunately, most of those deaths are taking place in the relatively few number of infections that we're seeing. About 600 or so from Central and West Africa account for 61% of the deaths globally. Now, we see, unfortunately, too, that there's a racial and ethnic component to this that is very close to what we've seen with COVID-19 as well as with HIV. So with COVID-19, we recently marked over 1 million deaths here in the United States. One thing that's really important to know about that is that those deaths were primarily among Black and Latino populations in the US. And even when you break it down by age and race, you find that Blacks and Latinos were more likely to die from COVID-19 no matter what age cohort they were in. Whether or not they're younger, whether or not they're middle age or older, it was more likely to have Black and Latinos who are dying from COVID-19. And unfortunately, the thing with COVID-19 is that the impact by race and ethnicity happened very quickly. We published a study that made a lot of national news when there were no national data available, where we looked at the counties that were disproportionately African-American to see what mortality rates were for COVID-19, as well as new infections for COVID-19. And what we found is that only 20% of counties in the US have a greater than average number of Black residents, but they still accounted for nearly 60% of COVID-19 deaths and over half, 52% of COVID-19 cases in the US. And that was very early. That was as of May. And we found that the associations with COVID-19 cases in these Black counties was the social determinants of health, being uninsured, employment status, as well as the number of people in shared housing space. And unfortunately, we found other associations as well. We published a second paper looking at the composition of counties in the US for COVID-19 cases and deaths. And what we found is that those counties that are disproportionately white had fewer COVID-19 cases or deaths. Those counties that are much more diverse, you saw where most of the COVID-19 cases and deaths were taking place. And all of that remained the same even when you accounted for population size. Now, unfortunately, we see the same racial disparities for HIV as well. These are data showing the number of infections that take place each year. And you can see that there is decidedly a greater number of infections among marginalized racial populations, as well as sexual minorities, where Black MSM are the most number of new diagnoses for HIV, followed by Latino MSM, and then white gay men. And then we see as well that African Americans, heterosexuals, as well as Latino heterosexuals are disproportionately impacted as well by HIV. And unfortunately, this is not something that's new. This is something that we've seen for quite some time for the HIV epidemic, where at the very beginning of the epidemic, new infections were greatest among whites, and particularly white gay men. And that changed by the late 80s, where you saw the epidemic becoming blacker and browner, where African Americans comprise the greatest number of new infections that take place. And that's something that exists through this day, where the most number of new infections are among African Americans. And what we're also seeing recently is that Latinos are overtaking whites in terms of new infections for HIV. So this disease has been becoming progressively blacker and browner, and just like with COVID-19, disproportionately affecting communities of color. Unfortunately, we're seeing exactly the same thing with monkeypox. Despite the fact that the monkeypox outbreak took place very early on, is just a couple of months ago, our first case being diagnosed in May, you can see here from the CDC data just a progression by race and ethnicity of monkeypox diagnoses, where Latinos are in a purple, African Americans, or rather Latinos are in a green, African Americans are in purple, and whites are in blue, that you can see as time goes on, there are fewer and fewer white diagnoses among whites, more and more diagnoses among Latinos, and then more and more diagnoses among African Americans, with Blacks and Latinos now accounting for nearly 2/3, or actually greater than 2/3 of monkeypox diagnoses. And I think one of the questions we all have is whether or not monkeypox is going to become endemic among MSM of color. Is this something that we're going to see over and over again among MSM of color and essentially disappear in other populations? And there's reasons why people believe that that could actually happen. One of that is the fact that we're seeing these treatment disparities. We were talking about tecovirimat or MPOX, but we're seeing many disparities that are taking place with MPOX, where those men who are more likely to be diagnosed with monkeypox, Latino MSM or Black MSM, are less likely to receive treatment for TPOX, whereas with white gay men, they are less likely to be diagnosed with monkeypox currently, but are still more likely to receive TPOX. And this is something that we've seen with COVID-19 as well, with COVID monoclonal antibodies. And these are data that CDC provided, where you saw over time that whites were more likely to get this treatment for COVID-19, but African Americans as well as Latinos and others really lag in terms of having access to that treatment. And unfortunately, this is something that's also part of the narrative for quite some time with HIV. As soon as antiretroviral therapies became available, that allowed people to live longer, that allowed you to not transmit HIV to a loved one, you could see that the disparities in mortality rates between whites and Blacks living with HIV actually increased when antiretroviral therapy became available. And that was because African Americans were less likely to have access to it as compared to whites. And we saw comparatively more deaths among African Americans, while the death rate was decreasing among people living with HIV who were white. And unfortunately, we see the same thing being replicated to this day with pre-exposure prophylaxis, despite the fact that African Americans and Latinos are disproportionately impacted by HIV. You see that African Americans and Latinos are far less likely to be on pre-exposure prophylaxis as compared to their white counterparts. So, this continues as well when we look at the picture of vaccines. We saw that for COVID-19, that African Americans and Latinos and others were far less likely to receive the COVID-19 vaccine for many different reasons. We're seeing the same thing replicated again from monkeypox, and these are data from CDC. updated from this week, which is showing that among white gay men, about 28% of diagnoses for monkeypox, 50% of the vaccines that are being distributed or being taken. For Latinx MSM, 28% of diagnoses, but only 24% of vaccines. For Black MSM, it's even more disjointed, where we're 38% of monkeypox diagnoses, but only 13% of the vaccines that are out there. And what this does is that this creates a gap that widens over time, where you could potentially see diseases becoming endemic in specific populations. That's something that we began to see very early on with COVID-19. These are data from here where I am in Washington, D.C., where you can see that COVID-19 cases were always greater among African Americans compared to whites in DC. But this is what happened as soon as the vaccines became available. You saw that COVID-19 cases started to decrease among whites because they were more likely to get the vaccine, to get access to it. And then you saw that COVID-19 cases in Washington, DC became progressively more and more concentrated in African American communities, with several different reporting periods where all of the COVID cases that were being reported were among African Americans. This is something that we've seen as well with HIV, where disparities have worsened over time in the past 40 years of the HIV pandemic. And these are data that the CDC released for the 40th observation of HIV, where they're looking at HIV incidence from 1981 through 2019. And you can see that incidence was very high among whites in 1981. They were 56% of new infections. By 2019, 25% of new infections. But we see again with Blacks and Latinos how the disease becomes blacker and browner. In 1981, Latinos were only 16% of new infections, nearly double to 29% of new infections by 2019. Among African Americans, we were 30% of new infections in 1981 and then jumped to 41% of new infections by 2019. So with each one of these infectious diseases, there's a predictable pattern where it begins to affect marginalized populations most over a period of time. And what we've seen with COVID-19, we're seeing with, we've already seen with HIV, and we're seeing with monkeypox. The other thing that is really important for us to realize too is that at this time when we're dealing with this viral storm, what we're dealing with is a period of syndemics, where we have these overlapping epidemics that take place that really magnify some of these disparities that we're seeing, because you see with the HIV epidemic, COVID-19, monkeypox, even substance use, that all of them disproportionately affect communities of color. So we see these outcomes that are different as well. So for instance, we've seen, a peak in gun violence among Black youth from 2020, where the COVID-19 outbreak took place. We're also seeing greater maternal mortality among African-American women, where you could see, again, this progressive increase by 2020 that far eclipses many other women by race and ethnicity. And it really shows this issue of these overlapping epidemics that disproportionately impact many of these communities by race and ethnicity. The other thing where we see these syndemics is the syndemic between monkeypox and HIV. One thing that's very clear is that monkeypox has really situated itself in networks of HIV positive MSM. So I'm on calls with the European CDC, where about 40% of diagnoses are among HIV positive MSM. Here in the United States, about 40% as well of diagnoses for monkeypox are among HIV positive MSM. But the really interesting thing is to look at the racial breakdown. It's just astounding the degree to which this disease is attacking individuals who are HIV positive. So we see for Asian MSM, among Asian MSM with monkeypox diagnoses, 22% were HIV positive. For white MSM, among those who were diagnosed with monkeypox, 30% were HIV positive. The numbers are huge for Latino as well as Black MSM. For Latino MSM, those diagnosed with monkeypox, 41% were HIV positive. And then for Black MSM, those diagnosed with monkeypox, 6 in 10 are HIV positive. So we're seeing the degree, this interplay between these different viruses and diseases, now with monkeypox and HIV. And we see that interplay in how it actually, inhibits some of the goals that we have, such as ending the HIV/AIDS epidemic. To end the HIV/AIDS epidemic, we need to make sure that people have access to pre-exposure prophylaxis. We need to make sure that people who are HIV positive are in care and virally suppressed. But the problems that we're seeing right now now is that, unfortunately, we see fewer African Americans. It doesn't matter which population, men, male, female, youth, MSM, IDU, who are less likely to be sustainably viral.
Greg, we lost your audio. You may be muted.
Oh, that's odd. Can you hear me now?
Yes.
Oh, great. Yeah, I wasn't sure what happened. Thank you. But what we're seeing is that, unfortunately, because we have less viral suppression among African Americans compared to many other groups, we're probably going to see more complications for monkeypox in these populations. And that's certainly something that we're already seeing. CDC is saying that there are greater hospitalizations among people living with HIV versus those who are HIV negative once they're diagnosed with monkeypox. And of the 2 deaths that we've seen in the United States from monkeypox, it's been among people who are immunocompromised, not necessarily HIV positive, but having some sort of immune suppression that's taking place where some of these people are sick and they have died from monkeypox, potentially died from monkeypox complications. This could disproportionately affect Blacks and Latinos because we're less likely, if we're HIV positive, to be on antiretroviral therapy, which means that we're more likely to be immunocompromised. I think the other issue that we need to think about as well is looking beyond this outbreak that's taking place. There are long-term consequences that are associated with monkeypox, long-term consequences that are associated with COVID-19, as well as long-term consequences that are associated with living with HIV. So for instance, each one of these conditions are associated with cardiovascular disease and heart disease, as well as a host of many other issues. And one of the questions that I think we're probably going to see coming from NIH and others are, what are some of the long-term consequences for people living with HIV, irrespective of race or ethnicity, if you have also been diagnosed with COVID-19 at some point and then subsequently diagnosed with monkeypox? And I think those are some of the other issues that we're going to have to start thinking about. As with any infectious disease, there is always stigma. There's always a group that you have to blame. We've seen with HIV that, you had the acronym GAY, got AIDS yet. That was very popular, unfortunately, in the 90s. With COVID-19, we saw a rise in anti-Asian hate and bashing of Asian populations. With monkeypox, we're seeing the same thing with a lot of homophobia on the rise. Just 2 blocks away from me, where I live in Washington, D.C., a couple of a gay couple were attacked and beaten viciously 2 weeks ago, where somebody was shouting that they had monkeypox, even though neither one of these men had monkeypox. We're seeing this online. There's a young African-American man who's diagnosed with monkeypox. He was self-isolating, but he was living alone. He didn't have access to food. He went to McDonald's and used contactless so that he could get food. And people were castigating him and punishing him online, saying, how dare you go out with monkeypox? But of course, if you're self-isolating and you don't have any other resources or people to help you, you need to get food. There's also a Latino gay man who talked about boarding a flight going back to Palm Springs, where the person next to him said, do you have AIDS or monkeypox? And when the guy refused to engage with him, the man who just got up and changed seats. And, it's just amazing that somebody could say something like that to you, just looking at you, knowing that you're gay and saying, hey, you must have HIV or monkeypox. I think one of the bigger issues that we're seeing with the monkeypox outbreak as well is the degree to which it's really leaving men who are impoverished or poorer in really dire straits. If you're diagnosed with monkeypox, you're supposed to isolate for 2 to 3 weeks. Many people can't leave their jobs over a period of time like that. They're one paycheck away from losing their home or not being able to pay their rent, etc. And we're seeing this over and over again, where many of these younger men or men who are destitute who have monkeypox, it's leaving them in financial ruin by having this self-isolation. And what that means is that there are some people now who might suspect that they have monkeypox, but if they know that they can't take up time off of work, are just not going ahead and getting diagnosed. And we're hearing about that over and over again in several different clinics and other places here in Washington, D.C. Now, what are some of the things that we could do to address some of these disparities? Luckily, there's some great things that are already taking place. So, for instance, the Ryan White HIV/AIDS program, it's a program really for indigent people living with HIV in the United States. We've seen some really great things taking place in terms of upping viral suppression by addressing the social determinants of health, such as access to healthcare, income, transportation, where they were able to up the viral suppression for African African Americans over a 10-year period, for transgender populations, MSM, Latinos, and others. That's something that is really important and can get us to more health equity rather than some of these disparities. The other thing that I think is important as well is that we see a reduction in disparities in the Veterans Administration as well as the armed services, where there really is a premium on health equity. If you're in the Army or any of the armed services, if you're a veteran, it doesn't matter what race or ethnicity you are, everybody is supposed to be treated exactly the same. And that's just the way that the Army and the Veterans Administration and everything is. And what you see is in study after study, that health outcomes for people who are in the armed services are actually better than in the general population. And specifically, the racial disparities are much more minimal than what we see in the general population because of this emphasis on health equity. And with COVID-19, we've actually seen in the Veterans Administration that vaccinations for COVID-19 are bucking the trend where you see Blacks as well as Latinos and Asians are outpacing whites in being able to get access and being vaccinated in the Veterans Administration. And that's very different than what we're seeing nationally. So there has to be something from that model that we could expand nationally to really reduce these types of inequities. The other thing, of course, is Medicaid expansion. There are many different states that have not expanded Medicaid. Many of those states are in the southern US. Also states where there's large populations of African Americans and Latinos who are less likely to be insured. But we could see from this analysis from Kaiser Family Foundation, those states that have expanded Medicaid have far fewer people who are uninsured as compared to those states that have not expanded. And why this is important is because in many places, if you are not insured right now, it's going to be very difficult for you to get tested for monkeypox. You would have to pay for your own testing. This has implications for many different ways as to whether or not people even want to interact with the healthcare system. The other thing that I think is important to look at too is really the resilience of many of these communities in the midst of these epidemics. The reason that I became involved in HIV was because I grew up in New York City. I grew up in Greenwich Village, and I saw all around me people who were literally dying from HIV. I had friends in the 80s as well as the early 90s who were wasting away, and I wanted to do something about it and got into public health and eventually started working on HIV both domestically and globally. What we're seeing with the COVID-19 pandemic and with monkeypox and all these other rises in infectious diseases is that we're seeing more students who are applying to public health programs, to medical school programs, particularly among Black as well as Latino populations. We're also seeing a boom of Black-owned businesses, despite the financial catastrophe that we had with COVID-19. So we're seeing a lot of resilience in these communities, which I think is important. And with that, I just wanted to you and to say once again that we're living in an era of a viral storm. It's disproportionately affecting some populations compared to others, and that this is something that we're going to continue to see over and over again, where there are some populations that bear the burden of infectious disease until we actually do some formative things in our society to try and fix this. And with that, I just wanted to leave with you. There's a quick take that we published on some of the racial disparities on monkeypox. I did this with Georgetown University, and a recent paper that I published with colleagues in the American Journal of Public Health around some of these disparities in monkeypox. Thank you, and look forward to any questions that you might have.
Thanks, Greg. So Dr. Furch, that was a great kind of introduction to monkeypox. And Greg, that was a really great primer on kind of some of the health disparities we're seeing with a lot of these infectious diseases. And, you could have talked more about, chlamydia, gonorrhea, syphilis. I mean, the list kind of goes on. But I will be brief because I want to leave some time for questions from the audience. I just want to briefly talk a little bit about kind of what we're seeing as far as monkeypox in North Carolina and Durham County specifically in some of the health disparities. So of the over 24,000 monkeypox cases in the United States, we've seen about 450 cases here in North Carolina, and in Durham County, about 3 dozen. North Carolina in general, about 98% of cases have occurred in men, and the age ranges largely mirror the age ranges nationwide. And then about 69% of cases have occurred in Black or African American folks. In Durham County, what we're seeing is, largely demographic-wise, largely mirrors the demographics of the state. Unfortunately, as far as the vaccinations, although we've vaccinated, we've given out over 16,000 vaccines in North Carolina to over 11,000 people, only about 27% of those vaccines have gone to Black or African-American individuals. So, a huge disparity in terms of who's getting monkeypox and who we're reaching as far as vaccinations in North Carolina. And again, this largely, mirrors kind of the statistics nationwide. On a local level here in Durham County, we've really tried to reach those most vulnerable communities as best as we can. We have a vaccine clinic here in our Health and Human Services building that's open 5 days a week. And we've really tried to do some outreach events into the community as well. I think, we recognize, as well as, a lot of other people around the country, that, getting out into the community is important. And so we've had a number of vaccine outreach events. For those of you that are local here in North Carolina or Durham County or the surrounding area, we are coordinating with Duke Health this Saturday, and we will be vaccinating folks that are interested with Jenius vaccine at the Durham Pride event. The festival is from 12 to 4, and so that'll be the main time that we're vaccinating. Durham County Department of Public Health will also be doing STI testing for folks that are there and interested. But I think, last thing I'll kind of leave you with is, I think, as much as folks on this call can help us, get the word out kind of about monkeypox and risk factors, and try to, reassure your friends and family members that, the Jenius vaccine is one of the best tools that we have in our toolbox, and it's safe and effective. And, that's really the primary means that, we can protect ourselves from getting monkeypox. And so, please help us get the word out. Again, if you're in Durham County or the surrounding areas, come out on Saturday to Durham Pride. And if you want to get vaccinated, we'll, along with Duke Health, we'll be there.
Thank you guys so much. This has been very informative. And as you all mentioned, like the parallels to monkeypox and HIV, which is astonishing, and that just further implicates and further how we need to work together to stop HIV. It's just so astonishing that, that some of the same things we saw 80 years, like in the 80s is now in 2022 with another disparity. So, and it's still affecting the same people. So we definitely have some work to do. But again, we appreciate you guys as panelists and doing the work that you guys do, because like I said, we have to do this together. I know there were a couple of questions in the chat. I'm not sure if they've all been answered, but one question is there a strategy to change the access to remedies for these disease for people of color? How do you get a buy-in from the people who can increase access for people of color? So that's one question. I don't know who wants to take it.
Sure. So, no, Brianna, go ahead.
Oh, I was just going to say, I think that the buy-in starts here with us, right? Like coming to these webinars, engaging in your community as physicians, healthcare workers, we are public health servants. So I think in each of our clinics, just kind of making sure to answer questions, be available, and just kind of go to these community events. And that's how you get community buy-in, be visible, decrease the stigma, and, make it relatable. So, as a healthcare worker, you make COVID, explain all the facts, make it relatable, make it understandable, and that's how you get the buy-in. That's what I've seen anyway.
Yeah, I agree. I'd say that, really show up and be there for the community. And the one thing that I've seen in my public health career is that it really doesn't matter the background of the person who is doing this work. That, as long as you're trusted by the community, that you don't necessarily have to be someone who is from the community. And I've seen that over and over again, is, people who've really been there for quite some time, who've demonstrated some trust, who are doing the work, really have some amazing tie-ins with the community. And I think, it's very clear that we have to address some of the history that's there. Even though a lot of people don't know specifically about the Tuskegee experiment, it certainly informs people's hesitation towards getting vaccinated, either for COVID-19, for monkeypox, and certainly even just the flu. On a yearly basis. And that's something as a society that we really need to reckon with, and to be very honest about, some of these things that have taken place in the past, and how it shapes people's view of health and healthcare, and really address that in a forthright manner so people can understand this was a history, but this is what we're trying to move away from, and to really, make sure that we're placing you at the center of health and healthcare, as well as your family.
And just to take a deeper dive, the person that asked the question wanted to get a deeper dive into like policymakers and stakeholders. How can we get the buy-in, or what can we do to ensure the buy-in from stakeholders and politicians and policymakers?
I think I'll answer really quickly for policymakers, because most of my work is doing with Capitol Hill here in Washington, D.C. You get buy-in in different ways. Sometimes you bring in constituencies to policymakers, so people who are within their communities that they represent, to come in and to tell their story, how they've been affected by HIV, by monkeypox, by COVID-19. That's one way to get buy-in. Another way is to, speak with some of the local papers, put in an opinion in some of the local papers. Many of these policymakers look at what's in the newspapers in their hometowns, and respond to that. I think the other way too is, if you're in a community where, talking about race or ethnicity or equality may not get you as far with a policymaker. Another way that you could actually use is to talk about the economics behind this. I mean, when we saw the outbreaks of HIV that took place in Indiana several years ago, that was associated with the opioid epidemic. They didn't have a syringe services program. One thing that really got syringe services programs started, not only in Indiana, but in places such as Tennessee and other places that have not had syringe services programs, is to look at how much that costs economically to have an outbreak among 200 people who were diagnosed, 90% of whom with HIV and co-infected with hepatitis C. And when you do that cost analysis and what that cost analysis is associated with, that's another way to really bring people in and say, the alternative cost is prevention, which is very little, as compared to what you're going to be paying on the other end if this many people are part of an outbreak. So those are some of the different ways to get policymakers on board.
Thank you so much for that. And then we also have a question asking about how are children affected by monkeypox? And then I know there was a question in regards to pregnant women getting vaccinated. So can we kind of tie those questions, answer those questions kind of together, or at the same time, not together, but at the same time?
Yeah, I can take a stab at tackling those. So the Jynneos vaccine is very safe. It is although it's a live virus, the virus has been modified so it can't replicate. So even if you're immunocompromised, there is no chance that the virus can replicate and then cause an infection, like Dr. Furch said earlier. So not only is it safe if you've got comorbidities, if you've got comorbidities, you should especially get the vaccine. So that includes people with HIV, even if your CD4 count is low. If you're pregnant, it's fine to get. Again, you can't get the virus from the vaccine, so there's no chance that you get vaccinated and then pass the virus on to your child. So the only comorbidity, or the only reason not to get the Jynneos vaccine is if you've had an allergic reaction to the Jynneos vaccine. That's it. And then I think, regarding the second part of that question, virologically, monkeypox is related to smallpox, but it's also related to chickenpox and cowpox and other pox viruses. So it's really, monkeypox is just as different from smallpox as it is from chickenpox. And so I hope that, you know, right, doesn't think, well, this is similar to smallpox, and so it's equally as dangerous. It's not. They're two different viruses. And, you know, although, you know, in endemic areas of the world where monkeypox is endemic, you know, it does, you know, have kind of low mortality rates. We've seen very little deaths in the United States and Europe from this current outbreak. There have been about a dozen or so, but, you know, that's in the context of tens of thousands of cases. And so not nearly as likely have a chance to, you know, get severely ill or die as smallpox. And then children have gotten diagnosed with monkeypox. There's probably been maybe a dozen or so cases in the United States. In endemic areas where monkeypox is endemic, kids typically are the ones getting monkeypox, and it's from close contact with other kids or parents or siblings. We've just seen it, you know, with this current outbreak. It's really behaved differently and been transmitted differently. So not surprising that, you know, we're seeing some kids get monkeypox.
Thank you so much. I know that we are rounding out our hour, but there was also a question in regards to having, if Dr. Birch or anyone on any of the panelists, this may need to be a charge for the Center for Black Health and Equity. The question was asked, was there a one-pager of facts that we could use at church? So like I said, it may be a charge for us, but if any of the panelists have or know of that would be helpful. And yeah, so I guess Dr. Birch, do you know, I mean, because I know Fred Hutchinson does a lot of faith-based initiatives with their research as well. So
I'm looking just now, and I feel like the CDC is a wealth of CDC.gov is a wealth of information. And so if you go to, I'm right now on CDC.gov, and I just typed in monkeypox, and I just see so many things, infographics about outbreaks and cases, how it spreads, what to do if you're sick, all of these things, prevention, protecting others. And so just quickly, I'm only guessing that you can just probably find something here that will be applicable in our faith groups. But again, if you feel like you are having these signs and symptoms, these flu-like symptoms, be on the lookout for the rash. And again, this rash is going to present, it's going to be painful. And so then go to your doctor and have that discussion and ask them, you know, I feel like I would like to get tested. Perhaps I've come in contact with monkeypox. So, but otherwise, you know, self-isolate, wear your mask, continue to practice all your self-hygiene things, wash your hands, wipe down surfaces regularly, keep a distance from people, just in general, cover your coughs. But if you continue to do those things, be on the lookout for these flu-like symptoms and the rash, and then go ahead and go to cdc.gov, and there's a wealth of information there for everyone.
Thank you so much for that. And again, thank you to the panelists for giving us this wealth of knowledge. We appreciate you guys.